Now, can you see that?
Yes.
Okay.
Thank you.
Okay, Olga, one more second. Olga?
Yeah.
Is there some way that we can eliminate everybody's picture from the side? Okay. Modern methodology. So actually the most important thing that I probably didn't tell you is that I don't own a computer. I have never touched the on-off button by a computer. And that is why Olga is always at my side to make sure that these things go well. So I think we're back on track here. So as I said earlier, the three core defects that are present in patients with type 2 diabetes are the insulin resistance in the liver, which is responsible for fasting hyperglycemia, lower left, insulin resistance in the muscle, lower right, postprandial hyperglycemia, and beta cell failure. But we have now at least 5 other abnormalities that we have to deal with. And when I gave the Banting lecture in 2008, I referred to them as the ominous octet. So let's first start in the upper right here with the fat cell. What's driving the epidemic of diabetes, of course, is the epidemic of obesity. And as we continue to eat and we take in excess calories, initially those calories can be stored in the fat cell. But with time, we fill up the storage capacity. And then what we see is the fat cells become very resistant to insulin. They start to break down the fat, and they release the fat into the bloodstream in the form of free fatty acids. Now, most of you probably have never measured the plasma FFA level in any of your patients. But if you look in diabetic patients or in people who are overweight, there's a marked increase in the plasma FFA levels. So what is the problem? Well, elevated FFA levels inhibit insulin secretion and on a long-term basis actually cause beta cell death. In the lower left, they drive hepatic glucose production, and this is responsible for the elevated fasting glucose concentration, and they cause insulin resistance in muscle. So this defect here at the level of the fat cell exacerbates the underlying 3 core defects. We also know that the gut plays a very important role in the pathophysiology of type 2 diabetes. The gut is a giant endocrine organ. And every time we eat a meal, we release 2 incretin hormones, glucagon-like peptide 1, GLP-1, and GIP, glucose-dependent insulin-trophic polypeptide. Those 2 incretin hormones collectively, GLP-1 and GIP, are responsible for 70% of the insulin that we release during the meal. So what goes wrong with this incretin axis? Is it that we don't make enough of the incretin hormones, or is it that there's resistance to the effect of the incretin hormones in the level of the beta cell? Well, it's the later. If we actually measure the GLP-1 and GIP levels, they're pretty close to normal. The real problem is that your beta cells are very resistant to GLP-1 and GIP, and we can overcome this defect with GLP-1 receptor agonists and the DPP-4 inhibitors, the later of which we'll talk a little bit about later in the program. We also know here at 9 o'clock that the alpha cell plays a very important role in the pathophysiology of the disease. So fasting plasma glucagon levels are markedly increased in diabetics, and when we eat a meal, the glucagon levels fail to suppress normally. So these elevated glucagon levels drive hepatic glucose production and contribute to the excess glucose production throughout the sleeping hours. And again, we have drugs here which will knock down the glucagon in terms of the GLP-1 receptor agonist and the DPP-4 inhibitors. At 3 o'clock, here is the kidney, and we're going to talk a lot about the kidney today. But every day of our life, the kidney filters about 180 grams of glucose, but all of that glucose is reabsorbed in the kidney. In people with type 2 diabetes, even though the blood sugar level increases and can increase in excess of 200 milligram per deciliter, very little of that glucose gets excreted in the kidney. so that the threshold for the kidney spillage of glucose into the urine is markedly increased. So the kidney, instead of dumping this excess glucose into the urine, holds on to it. And we'll talk a lot about the Sglt2 inhibitor class of drugs, because these drugs block glucose reabsorption in the kidney, and they allow the glucose to be excreted into the urine. And then down at the bottom is the brain. The brain plays a very important role in the pathophysiology of type 2 diabetes, but in a somewhat different way. So every time we eat a meal, there are signals that are generated that go to our brain that tell us to stop eating. Well, unfortunately, in people who are overweight and people who have type 2 diabetes, even if they're lean, these signals become disrupted, and the brain does not appreciate that the signal is being sent to stop eating. And in particular, we know that when you eat a meal, one of the most powerful hormones that's released is GLP-1. Now, GLP-1 is a very potent appetite suppressant molecule. Now, because the brain is resistant to GLP-1, we lose the signal that tells us to stop eating. So people who have type 2 diabetes tend to overeat, they gain weight. And when you gain weight, you become very, very resistant to insulin. And because diabetics, the genes are already, the genetic component of the disease are there, causing insulin resistance, when we superimpose the weight gain, the environmental component here of insulin resistance, your beta cells simply cannot secrete enough insulin to overcome all of this insulin resistance, and the beta cells start to fail. So it should be clear now that if we have 8 defects to deal with, we're going to require multiple drugs, and we're going to have to use drugs in combination to correct these multiple pathophysiologic defects. So in my opinion, the stepwise approach where we add one drug, we wait till we fail, and we add a second drug, wait till we fail, this is really not the correct approach to be treating type 2 diabetic patients. We should be using drugs in combination, and the drugs that we choose should be drugs which correct the underlying pathophysiologic disturbances. So for instance, sulfonylurea is a drug I don't use in my practice. They do initially work on the beta cell to increase insulin secretion, but on a long-term basis, this effect on the beta cell wanes. And so they really don't effectively maintain the reduction in A1C. And then lastly, we need to start very early in the natural history of the disease, because we know that with time, there's progressive beta cell failure, and we need to intervene with drugs that are going to preserve the beta cell function. Now, we have 6 major classes of drugs that can be used to treat our diabetic patients. We have Metformin, the sulfonylureas, the DPP-4 inhibitors, and then the more recent additions are the Sglt2 inhibitors, the GLP-1 receptor agonist, and we also have an old one, pioglitazone, which I personally like. We're not going to talk much about pioglitazone. In fact, we're not going to talk at all about pioglitazone, but we need to learn how to use these drugs in combination. Now, today, as I said earlier, we're going to spend the majority of our time talking about the Sglt2 inhibitors and the role of the kidney in the pathophysiology of type 2 diabetes, and a little bit about the DPP-4 inhibitors. So let's now start with looking at the kidney and how it contributes to normal glucose homeostasis and what goes wrong in people with type 2 diabetes. So when we go to sleep at night, our brain has an obligate need for glucose. So where does it get that glucose from? It gets about 75 to 80% of the glucose from the liver, and it gets the other 20% or so from the kidney. Now, the kidney contains very little glycogen, so all of the glucose that's being produced by the kidney to nourish our brain is coming from the gluconeogenic pathway. The kidney also utilizes glucose as a fuel, and it turns out that the amount of glucose which is taken up and metabolized by the kidney and the amount which is produced is about equivalent. So if you were to measure the net balance of glucose across the kidney, it's 0. And we'll come back to this glucose production by the kidney in a few moments. The kidney also plays a very important role in glucose reabsorption. So every day in you or I, with the normal fasting glucose, we filter about 180 grams of glucose. And in you or I, all of that glucose is reabsorbed. The majority of it, some 80 or 90%, is reabsorbed by the Sglt2 inhibitor. S stands for sodium, GL for glucose, T for transporter. And then downstream of the Sglt2 transporter is the Sglt1 transporter, and it takes back the remaining 10 to 20% of the filtered glucose. So over the years, using radio-labeled glucose, we've been able to look at individuals, non-diabetics first. I'll share with you what happens in diabetics in a second. They go to sleep at night, they wake up in the morning. So throughout the sleeping hours, their body produces glucose at about 1.8 milligram per kilogram body weight per minute. Don't really worry about the units or the numbers, more focus on the percentage. So where is this glucose coming from? As I said, 15 to 20% is coming from the kidney. Another 80 to 85% is coming from the liver. Now, what goes wrong in the diabetic? Throughout the sleeping hours, the diabetic overproduces glucose. So where does this overproduction of glucose come from? You can see that there's a significant overproduction of the glucose both by the kidney and the liver. So now this big increase that goes from 1.8 to 2.7 milligram per kilogram body weight per minute, about 25% is coming from the kidney, and about 75% now is coming from the liver. So both the liver and the kidney contribute to this overproduction of glucose throughout the sleeping hours, and this translates to an increase in the fasting glucose concentration in the morning. Now, to drive this point home so the quantitative view can understand what we're talking about, let's take a typical diabetic patient that you might have in your practice. He has an A1C of about 8. The mean glucose in this person is about 160 milligram per day. And let's give him a normal glomerular filtration rate, 180 liters per day. Well, in this person, the kidney would produce an extra 50 grams of glucose, primarily throughout the sleeping hours, and add that to the systemic circulation. But now there's another problem that we have to deal with. In you or I, shown in the bottom, we filter about 180 grams of glucose every day, and that's what we reabsorb. Now, the diabetic has a markedly elevated plasma glucose concentration. So the typical diabetic who has an A1C of 8 is now going to filter and reabsorb about 280 grams of glucose. So instead of reabsorbing 180 grams, he's reabsorbing 280 grams of glucose. He's reabsorbing the kidney an extra 100 grams of glucose every day. In addition, the kidney is producing 50 grams of glucose. That means every day of this diabetic patient's life, the kidney is contributing an extra 150 grams to the systemic circulation. And this is an enormous amount of glucose and playing a major role in the hyperglycemia in our diabetic patients. And that's why it is critical that we have medications that are going to restore these abnormalities at the level of the kidney. So let's take a little bit more in-depth look at how the kidney handles glucose. So as I said earlier, every day of our life, the kidney filters about 180 grams of glucose, and is shown here down at the bottom. None of the glucose ends up in the urine. So this entire 180 grams of glucose is reabsorbed. So how does this happen? In the early proximal tubule, there's an Sglt2 inhibitor. It takes back 90% of the filtered glucose. And if it does its job, the Sglt1 transporter will take back the other 10% of the glucose, and the net result is none of the filtered glucose ends up in the urine. Now, what goes wrong in the person with type 2 diabetes? Before I show you what goes wrong in the person with type 2 diabetes, I first need to review with you in a little bit more detail how these tubules in the kidney reabsorb glucose. You learned all of this when you were in medical school many years ago, but I'm sure you thought it wasn't important and you immediately deleted it from your memory bank. But I know at some point it was there because you passed the test, okay? So let me bring you back to your medical school days. So what I'm going to plot for you on this slide is the plasma glucose concentration going from a normal fasting of about 80 to 90 up to 300. And then on the y-axis, the amount of glucose that's reabsorbed and excreted. So as I raise your blood sugar level from 100 up to 200, none of the glucose that's filtered appears in the urine. But once I get to 200 milligram per deciliter, this is the threshold for glucose spillage to the urine, and all of the glucose that's filtered above that threshold now is excreted in the urine. Now, if I were to plot the reabsorptive curve, it would be the mirror image. As I raise the glucose from 100 to 200, all of the glucose is reabsorbed. But now at 200 milligram per deciliter in the plasma, I've now reached the threshold, and everything above that which is filtered ends up in the urine. Now, in actuality, there's not a sharp break in this threshold. So you start to spill glucose into the urine when your blood sugar gets to 180. So I'm going to use this sort of as we go forward as the threshold for glucose spillage in the urine. Now, what goes wrong in the person with type 2 diabetes? As I raise your glucose from 100 to 180 in a normal person, no glucose appears in the urine. But then after that, all of the glucose, which is filtered, ends up in the urine. And this is you and I with a hemoglobin A1C of about 5%. Now, what about in a person with a pre-diabetic situation who has a A1C, it's about 6.4 to 6.5. Well, you can see, and these data are all published in Diabetes, as you can see the reference here, in this individual who has pretty good control, has an A1C of 6.5, the renal threshold is already increased to 205. And in a person with the hemoglobin A1C, the threshold is increased further to 220. And if the A1C now is 8.5, the threshold goes to 240. And if the A1C now is 9.5, the threshold is approaching 260 or above. So this is exactly the opposite of what we would like to happen. So as the glucose goes up in the diabetic patient, we would like the kidney to dump all of this glucose in the urine. We don't want the kidney to be hanging onto the glucose, exacerbating the hyperglycemia. But there's a paradoxical stimulus that's going to the kidney, and that stimulus is saying, the higher the glucose, hang on to the glucose more avidly. So we can block this by using the Sglt2 inhibitors. So how do they induce glucosuria? So remember, the Sglt2 transporter is responsible for 90% of the filtered load of glucose. So we would like to block this reabsorption by the Sglt2 transporter, and in doing so, we can enhance the excretion into the urine. Let's take a look now at what happens again in you or I. We are non-diabetics. I raise the glucose from 100 to 180, no glucose in the urine, and at 180, all the filtered glucose appears in the urine. Now, what about in the diabetic? Schematically, I've shown that the threshold is increased to 220. So you have to get above this before now all of that filtered glucose is excreted in the urine. Now, how do the Sglt2 inhibitors work? Now, these are studies which we've carried out with empagliflozin. They're all published in JCNM, but we also carried a very similar study with dapagliflozin. We haven't done with canagliflozin, but I'm sure that the results will be the same. So how low do we lower the threshold? We actually lower the threshold to 40 milligram per deciliter. You can see this is well below the fasting glucose. So if I were to give empagliflozin or dapagliflozin or canagliflozin to any of you who have a normal fasting glucose, you would start to pour out glucose in the urine. So in a diabetic who has a fasting glucose that's say 180 or 200, we're way below his threshold. He's going to pour out massive amounts of glucose in the urine. Now, because we're lowering the threshold to less than the fasting glucose, there is no such thing as a non-responder to the SGLT2 inhibitor class of drugs in people with type 2 diabetes, unless, of course, they have very advanced renal failure and their kidneys are not working very well and they have very low glomerular filtration rates. So you should ask yourself, if I lower the threshold to 40 milligram per deciliter, and I were to give this to a non-diabetic, why doesn't this person become hypoglycemic? Well, as soon as the glucose starts to appear in the urine, in you or I, there's a signal that's generated and it goes to the liver and it tells the liver to start producing glucose. And it produces an amount of glucose, which exactly equals to what comes out in the urine. So you cannot become hypoglycemic. So this is one of the major attributes of the SGLT2 inhibitor class of drugs. And as you'll see as we go through this presentation, these drugs have very powerful effects in terms of preventing cardiovascular events. So this has now become a drug which needs to be used by our cardiology friends. And I tell them, when I talk to them, I say, this is your drug. You don't have to worry about hypoglycemia. So you use this drug as you would use any other drug in the treatment of people with heart failure or myocardial infarction to prevent cardiovascular events. You do not have to worry about hypoglycemia as long as the patient is on sulfonylurea or insulin, other drugs which in and of themselves can cause hypoglycemia. Now, what is the experimental evidence that if we block renal glucose reabsorption, that we really can improve glycemic control? So many years ago, and I knew this from my nephrology days, that there was a drug called fluorescein that blocked glucose transport in the kidney. Fluorescein blocks both the SGLT2 and the SGLT1 transporter. So where does fluorescein come from? Fluorescein comes from the bark of the apple trees when the apple trees bloom in the spring. And so what we did is we carried out studies in animal models of diabetes and showed that if you were to take diabetic rats or mice and you treated them with fluorescein, you can completely normalize their blood glucose profile. And we also went on to show is that these drugs block sodium glucose reabsorption. So they're sodium glucose co-transporters. So when I block glucose, I block sodium. Let's just focus on glucose. So when I lower the glucose by having the glucose be excreted in the urine, I improve insulin sensitivity in muscle. And we also showed the molecular mechanisms by which this happened. We improved insulin sensitivity in the liver, and in the bottom in orange, we also improved beta cell function. So basically, we got rid of glucotoxicity. We also showed many years ago in people with type 2 diabetes that high glucose was a poison to your beta cell. It was also a poison to your muscle and caused insulin resistance. So if we had a drug that enhanced glucose excretion in the urine, as your blood sugar level came down, we would improve beta cell function and we would improve insulin sensitivity in the muscle. So these studies are wonderful, but then you can say, well, do we say the same kind of effects in humans? Are the fluorescein data that we demonstrated that could basically cure diabetes in rodents, are they applicable to humans? So this is actually the very, very first study in humans demonstrating that, in fact, SGLT2 inhibitors corrected the underlying basic defects. It was a very small study, but we used very, very sophisticated techniques. So there were 12 people who in this study were treated with dapagliflozin. These look like your typical patients. They're overweight. A1C is about 8.7, elevated fasting glucose. And at baseline, and then in follow-up 2 weeks later, we measured their insulin sensitivity with the insulin clamp technique. This is the gold standard for measuring how the tissues in the body respond to insulin. We're going to infuse insulin, raise it to the same level in the diabetics and the control subjects. And then with radio-labeled glucose, we can precisely quantitate how sensitive the body is to the insulin. How much glucose did you metabolize to a given rise in insulin? People also had an oral glucose tolerance test so that we can look at beta cell function, and we measured their glucose excretion, and then we repeated these studies after 14 days. So when we gave them the dapagliflozin, before in yellow, they excreted about 12 grams of glucose in the urine, and then you can see at day 1, 2, and 15, after administration of the dapagliflozin, renal glucose excretion increased to about 90 grams per day. So this drug clearly enhanced glucose excretion. What happened to the fasting glucose? It fell by 30 milligram per deciliter from 177 to 147. Now, this is just 14 days later. If we give them a glucose load, the postprandial glucose fell from 330 to 264. So it fell by about 75 milligram per deciliter. Now, that postprandial glucose is accounted for in part by the decrease benefit, is in part accounted for by the decrease in fasting glucose, as well as the increment above baseline. And so you can see that the increment above baseline was decreased by 40 milligram per deciliter, and to the far left in yellow, the fasting decreased by about 30 milligram per deciliter. So we're correcting both the fasting and postprandial rise. This is very, very important because there's now, I think, pretty good evidence that the spiking glucose, the rise above baseline, contributes significantly to the microvascular complications, as does the mean glucose level. So we're correcting both the fasting and postprandial glucose. Now, what about insulin sensitivity measured with the euglycemic insulin clamp? There was about a 35% improvement in insulin sensitivity. Now, insulin secretion during the OGTT increased about twofold as measured by C-peptide over the increment in glucose. But insulin secretion should not be equated with beta cell function. So the beta cell can sense how resistant you are or how sensitive you are to insulin. So if you want a real measure of beta cell function, you have to take the amount of insulin which is secreted and factor it by the severity of insulin resistance. And in these studies, we have two measures of insulin sensitivity. One is the Matsuda index during the OGTT. So you can see that the increase in C-peptide per increment in glucose, all factored by how insulin resistant you are, okay, or the disposition index, doubled. We also have an independent measure of insulin sensitivity from the euglycemic insulin clamp. And so again, when you look at this disposition index, this gold standard index of beta cell function, you see that we double beta cell function. So the Sglt2 inhibitors, okay, their major mechanism of action, of course, is on the kidney to promote glucose excretion. But now, as the glucose level goes down and we remove glucotoxicity, to the left, you can see we get a big improvement in insulin secretion, and to the right, a big improvement in beta cell function, and also, as I showed you earlier, an improvement in insulin sensitivity. Now, we subsequently went on to show that, in fact, you get exactly the same results if you were to do this study with empagliflozin. So here in the top, you can see the increase in insulin secretion before and then 2 in 14 days after treating the people with empagliflozin. Here is the rates of insulin-mediated glucose disposal. Again, you see that 35% improvement in insulin sensitivity. And in the bottom, the disposition index, which is the gold standard of beta cell function, also increased. Now, the beauty of this is that you see the effect within 2 days, and it's maintained out at 14 days. And you see it with both empagliflozin and dapagliflozin. As I said, we have not carried these studies out with canagliflozin, but I'm quite certain the results would be very similar. So if we come now back to the ominous octet, you see why the SGLT2 inhibitors are such effective drugs for treating our diabetic patients. First, their primary mechanism of action is on the kidney to enhance glucose excretion. As the glucose comes down, we improve insulin sensitivity in the muscle, and we have a major doubling of beta cell function. Now, the other beauty of the SGLT2 inhibitors is because they work on the kidney, they can be combined with any other class of anti-diabetic agents. So this is an ideal drug to use as combination therapy with a DPP-4 inhibitor, with metformin, or with a GLP-1 receptor agonist. So now let's turn to the clinical studies in humans with the SGLT2 inhibitors. Where do these drugs fit in sort of our clinical armamentarium? Now, I could show you data with dapagliflozin, canagliflozin, and they're going to look very similar to what I'm going to show you here with empagliflozin. Now, the next series of slides are all very similar, so I'm just going to take you through the coding so you understand. So the light orange is empagliflozin 10 milligram tablet. The dark orange is going to be empagliflozin 25 milligram, and the placebo is going to be in yellow. So here now, we're going to take drug-naive patients, and we're going to add either low dose or high dose empagliflozin compared to placebo, and we're going to look at the decrement in A1C. The starting A1Cs are at the top. You can see they're about 8. So these people are not that badly controlled, but despite this, we're seeing a nice drop of about 0.8 to 0.9% in the A1C. Here we are going to add now the empagliflozin to metformin. Here we added to people who are already on combination therapy with metformin, sulfonylurea, adding it to people who are on pioglitazone or on insulin. Because the drug is working on the kidney, different mechanisms than all these other drugs, you get a completely additive effect. Here's head-to-head against glipizimide. You can see an equivalent response in the two groups. Let's now look at what happens to body weight. And we'll start here, drug-naive patients. You can see down at the bottom, about 2.5 to 3 kilogram weight loss. Basically, the placebo is doing nothing. Same effect when you add it to metformin, combination metformin SU therapy. PO makes you gain a little bit of a weight, but nonetheless, you see you don't gain weight when you put the drug with PO. You lose weight, not quite as much as with the other studies. Same story with insulin. And this study, unfortunately, is a very unusual study, and the people with glimepiride lost a lot of weight because there was a big diet intervention. Normally, sulfonylureas make you gain weight, but again, you see in this group a very nice weight loss. Let's now turn to blood pressure. Because the drug makes you dump sodium as well as glucose in the urine, you get a little bit intravascularly volume depleted, so you would expect to see a drop in blood pressure. This is the change in systolic blood pressure. And you see across the board, it's dropping about 4 to 5 millimeters of mercury, no effect with the placebo. And it really doesn't make any difference what group of patients you're treating when you're going to see this very nice effect on blood pressure. So these are people who started with normal blood pressure. Now, if you look at people who are hypertensive, you get actually much greater drops in blood pressure, up to 6 to 10 millimeters of mercury. Now, as I said before, you can combine these drugs, the SGLT2 inhibitors, with any of the medications that are currently available. Now, the most commonly prescribed medication in the US, in the world, is metformin. So let's look at what happens when we combine empagliflozin with metformin, the decline in A1C. Let's start over here to the far right. The top of the bars are the starting A1Cs. They're about 8.5. Here's 100 milligrams of metformin, and this is 2 grams. And if you were to read across, you can see the drop in A1C is about 1.6. Here is empagliflozin, 10 and 25 milligrams. The drop is about 1.3. Here now, we can look at combining the lower dose of metformin with the lower dose of empagliflozin, or the higher dose of metformin with the higher dose of empagliflozin. And in this group here, if you look at the light orange to the far left, we're seeing a very nice drop in A1C of about 2%, which of course is outstanding. And about half of the patients are getting their A1C to less than 7, which is the standard recommended therapeutic goal. We also can combine the Sglt2 inhibitors, in this slide, empagliflozin, with DPP4 inhibitors. In the United States, we do not have Vildegliptin, so I do not have personal experience with Vildegliptin. I'm going to show you some published data in the literature, but I'm going to show you one study that we actually carried out using empagliflozin with linagliptin. We're looking at the time-related decline in A1C. This is linagliptin in green, and then here are the 2 doses of empagliflozin, 10 and 25 milligrams in orange, and you put the 2 together, lina and empha, the 2 doses, and you can see you get a nice drop in the A1C here. These people are pretty well, controlled for most people in the world. They're starting an A1C of 8, and they're ending up down here with an A1C of about 6.7, which is quite nice. So this is a very, very nice combination. Now, what about Vildegliptin? So this now shows you the effect of Vildegliptin on glycemic control in type 2 diabetic patients who are inadequately controlled on metformin. So in this study, if you just focus to the left, we're going to look at the A1C. You can see there's basically no change, a little rise in the A1C. And these people who are treated with placebo, and when I add the Vildegliptin, you can see this very nice drop of about 1.1% in A1C. If we look over here at the fasting glucose going up, and the placebo group, nice drop in the people treated with Vildegliptin, and placebo subtracted about a 30 milligram per deciliter drop in the fasting glucose. Now, this is from a study that's called the Verify study. So this is looking at Vildegliptin efficacy in combination with metformin, starting early in the treatment of people who are newly diagnosed with type 2 diabetes. And if you look here down at the bottom, 2 lines, now this is a very long study over 5 years, we're going to look at the percentage of people who are controlled with Vildegliptin alone versus the percentage of people with Vildegliptin plus metformin. And you can see that after 3 to 5 years, about 50% of the people getting the combination therapy have an A1C that's less than 7. So this emphasizes 2 points. Vildegliptin plus metformin, Vildegliptin plus metformin in this population is very effective in lowering the A1C. And it also emphasizes that, as I said earlier, you should be really starting people on combination therapy, not single therapy right from the beginning. Now, what about sort of Vildegliptin out in the real world? So this is a large study looking at thousands of patients. It's called the GUARD study. And you can now go into a very large database, and you can look and see, well, how are docs doing out in the real world when they start people on Vildegliptin alone to the left, or Vildegliptin plus metformin. And you can see these are very large numbers of people that we're looking at. And this is what you all can expect in the real world. And you see very nice drops in the A1C that are in the range of about 1.2 to 1.3. So in control trials, nice effect of Vildegliptin plus metformin. In real world, hands-on clinical experience, very nice effects as well. Okay, so in summary, what can we say about this class of drugs? Well, they correct this novel defect at the level of the kidney, where the kidney is hyper-reabsorbing glucose. As the blood sugar level now starts to come down because you're putting all this glucose out in the urine, we get rid of glucotoxicity, and we improve insulin secretion, and we also improve insulin sensitivity. We get nice reduction in A1C. because you're losing calories in the urine, as I showed you earlier, you also can expect about a 2.5 to 3 kilogram weight loss over the first 6 months. You can combine the SGLT2 inhibitors with any of the other anti-diabetic agents. Because you block sodium reabsorption and you get a little negative sodium balance, you drop the blood pressure, no hypoglycemia. So you're going to get nice improvements in glycemic control. And because we're correcting some of the cardiovascular risk factors, you might also expect to see beneficial effects in terms of prevention of cardiovascular events. So in summary, you can use the drug as monotherapy. You can add it to metformin, to sulfonylureas, pioglitazone, or any combination thereof. You can use it with a DPP-4 inhibitor, metformin. You can add it to insulin. In the United States, adding SGLT2 inhibitors to type 1 diabetics is not approved. It is approved in Europe with some pretty significant stipulations. I think it would be effective in IGT and IFG. We currently have a big study that's ongoing to look at this. And the higher the A1C, the higher the glucose, the more glucose you're going to dump in the urine. So the drugs are even more effective the higher the glucose concentration is. And of course, you can add it to a GLP-1 receptor agonist, which I think would be a great combination because as you'll see in a moment, the SGLT2 inhibitors give you cardiovascular protection. We have now very, very good data from 4 big studies that GLP-1 receptor agonists also give you cardiovascular protection. So I think this would be an interesting combination to look at together, okay? Before we go on to cardiovascular benefit, it's important to understand the safety issues. And I have to say this class of drugs is incredibly safe. The major side effect is general infections. In women, about 5 to 6% of people will experience a vaginal mycotic infection, usually easily treated with vaginal cream or diflucan. In the package insert warning in the United States, it says these drugs can cause urinary bacterial tract infections. But the simple fact is, if you look at all of the big cardiovascular intervention trials that have been carried on for multiple years, there's absolutely no increase in UTIs in any of these studies with any of the 3 drugs that have participated in these studies. You get mild intravascular volume depletion, but the kidney will never let you go beyond mild intravascular volume depletion. So from the practical standpoint, this is not a problem. Where you have to be careful is people who are already on a loop diuretic. In that group of people, you may want to consider cutting back the loop diuretic a little bit. No electrolyte disturbances. About 2 or 3% of the people might experience nocturia, meaning 1 more voiding per night. This, as I said, is not common, but maybe bothersome to this 1 or 2% of people. No negative drug-drug interactions. As I said, no hypoglycemia. There was an initial scare about bone fractures with canagliflozin, but this did not pan out with canagliflozin. And there's no signal at all for either empagliflozin or dapagliflozin in terms of bone fractures. There's also a warning in the package insert in the United States about acute kidney injury. As you're going to see as we go through this, this class of drugs actually is the best class of drugs that we have. At least as good as the angiotensin converting enzyme inhibitors, and probably better in terms of preventing kidney disease. So let's now look at the other big benefit of this class of drugs, their effect on cardiovascular disease. Now, a while ago, the Food and Drug Administration mandated in the United States that all diabetic agents, in order to have approval, must have a cardiovascular outcome trial. The first trial that was completed was the EMPA-REG outcome study. So in this study, there are 7,000 people who had had a prior cardiovascular event, were relegated to treatment with either placebo or empagliflozin. And in all of these studies, the FDA mandates that the primary outpoint be the MACE outpoint. So that stands for major adverse cardiovascular events. And there are 3 of them. cardiovascular death, non-fatal MI, non-fatal stroke. And you have to demonstrate, if you want to get a message in the package insert for superiority, that you beat placebo. And as you can see, the orange line here over the 48 months of the study is clearly below the yellow line. So empagliflozin is beating placebo. The hazard ratio is 0.86, meaning there's a 14% reduction in the MACE endpoint. Now, I also need to point out to you, because we're going to go through all of the 3 major cardiovascular studies, that some people like to say that there are differences amongst these drugs. In my opinion, all of the SGLT2 inhibitors basically doing the same thing. The difference in some of the outcomes are primarily related to the patient populations, not to the drug. So in EMPHA-REG, all of the patients had to have a previous cardiovascular event. So this is the sickest population. So now when we start to look at the individual endpoints, remember they're cardiovascular death, MI, and stroke, you should not be surprised to find that empagliflozin has a huge effect to decrease mortality. The hazard ratio is 0.62, means a 38% decrease in mortality. And this is really what's driving the MACE endpoint. And in fact, it shouldn't be surprising that what empagliflozin got approved for by the Food and Drug Administration was for decreasing cardiovascular mortality in patients with a previous cardiovascular event. Now, as a secondary outcome in these studies, they also looked at hospitalization for heart failure. And you can see here, hazard ratio 0.65. There's a 35% decrease in hospitalization for heart failure. And these drugs have very, very important effects to improve myocardial function and to reduce and prevent the development of heart failure. Now, next came the CANVAS program. The CANVAS program looked at the effect of canagliflozin on cardiovascular events. And in yellow at the top is CANVAS. In orange right below it is the EMPHA-REG outcome for the MACE endpoint of cardiovascular death, non-fatal MI, non-fatal stroke. And you can see that these 2 drugs are virtually identical, about a 14 to 15% reduction in the MACE endpoint. But there are some significant differences in the individual components of the MACE endpoint. So on the second line, you see cardiovascular death. In orange is EMPHA-REG. In yellow is the CANVAS program. So it's the second yellow dot and the second orange dot. And you can see the orange dot lies further to the left. And now, it shouldn't be surprising, however, that you got a better effect on mortality with empagliflozin. Why? Because in the CANVAS, 2/3 of the people got in because they had a cardiovascular event. 1/3 got in because they had risk factors, but they hadn't had a previous event. So again, yes, the little dots look like they're different, but I think it's more related to the patient population. Let's go down to the next line, myocardial infarction. You can see the yellow dot and the orange dot are basically superimposed upon themselves. So both empagliflozin and canagliflozin decrease myocardial infarction to the same extent. If you go down to the next line, this is non-fatal stroke. And I have to say I, as well I think as everybody in the world, was surprised by the fact that neither canagliflozin nor empagliflozin decreased stroke. Why? Because these drugs decrease blood pressure, so we would have expected a decrease in stroke. We didn't see it with either drug, and when I show you the data from DECLARE and dapagliflozin, also no significant decrease there, and this still remains somewhat unexplained. Now, I want you to now go down to, let's see, 1, 2, 3, the third major line, which is cardiovascular death and hospitalization for heart failure. And you can see, again, hospitalization for heart failure, markedly reduced, very similar by both drugs. And then if you go down to the very bottom, the renal composite, there's about a 45% reduction in the renal composite endpoint, which I will come back to in a few moments. Let's now put the three drugs side by side. So here you now see the DECLARE study added in yellow to the CANVAS program and to empagliflozin. So if you look at the MACE endpoint at the top for DECLARE, it did not quite reach statistical significance. The hazard ratio is about 0.91. Now, why do we not see this reaching statistical significance? Clearly trending in the right direction. This is the least sick population. So only 1/3 of people in DECLARE got into DECLARE because they had a previous cardiovascular event. The other 2/3 had risk factors. So if we look at cardiovascular death, you see that the yellow dot is right on the line. No decrease in mortality. If you look at the pink line, that's the EMPA-REG outcome. They're the sickest people. They get the greatest decrease in cardiovascular mortality. And if you look at the CANVAS program, the green dot, it's kind of intermediate. If you look at the next line, all three of them reduce non-fatal MI. If you look at the next set, none of them significantly reduce stroke. And if you go down a little bit further, HHF, hospitalization for heart failure, all three have a huge effect to prevent heart failure. And the bottom, all three have a huge effect to protect your kidneys. Now, what can we say about these SGLT2 inhibitor cardiovascular studies? What have they told us? Is it a class effect? In my opinion, and hopefully from what I've gone over with you, it's very clear it's a class effect. These drugs, or all three of them, are very cardioprotective. The major difference in the outcomes are more related to the patient population rather than the drug itself. Generalizability, meaning, okay, will we see these beneficial cardiovascular effects? And we look at people earlier in the natural history of the disease. And in fact, I think the data also support that that's true. So if we go to the dapagliflozin study, 2/3 of the people got in because they had risk factors. Canagliflozin, 1/3 because they had risk factors and not events. And those people still benefited, okay? And now I'm going to talk about the potential mechanisms. But in bottom, I think it's really important to understand these people who are being treated with these drugs are a very sick population. And the safety profile was incredibly good. So you have a class of drugs that's going to prevent cardiovascular events and is very safe. It's a class of drugs that we should be using in these high-risk individuals, okay? So how do these drugs work? I think the major mechanism of action of these drugs is related to their hemodynamic effects. They simultaneously cause a decrease in the preload because they decrease the intravascular volume, and they also decrease the afterload because they decrease the blood pressure. Now, something that's very interesting in all of these studies is even though we decrease the intravascular volume, the heart rate doesn't go up. So that suggests to me that there's also an effect to inhibit the sympathetic nervous system. And we also know that these drugs work on the aorta to decrease aortic stiffness. So when you measure the blood pressure in the forearm, it's decreased about 4, 5, 6 millimeters systolic. But when you measure in the aorta, what the heart's really pumping against, you're decreasing it by 8 to 10 millimeters of mercury. The other hypothesis, which has gained favor, is the metabolic hypothesis. We know that when you put the people on these drugs, that I switch you over from glucose to ketone metabolism. The ketone levels in people routinely treated with the SGLT2 inhibitors go up a little bit, maybe 0.2 to 0.5 millimolar. They're not even going to change the bicarbonate. But clearly, some people can get much higher levels, and some people can develop ketoacidosis. So why might this shift the ketone metabolism be important? So when the heart becomes ischemic, it would like to switch over to burn glucose, okay? But it can't, because we and others have shown that the heart, like skeletal muscle, is severely resistant to insulin. So it turns out that ketones are very avidly taken up by the heart. In fact, they're more avidly taken up than even glucose. So now you have a fuel that's metabolically very accessible to the heart. Now, in addition, when you burn ketones, you generate more ATP with less oxygen consumption. So they're oxygen sparing while generating more ATP. And so I think that there is evidence which is starting to accumulate that this ketone hypothesis, which was first put forward by Professor Farinini in Italy, may also be playing a contributing role here. There's a lot of other potential mechanisms that have been involved. I'm not going to take you through all of them. There's maybe at least in animal studies, an increase in mitochondrial function in number. These, of course, are the powerhouses where ATP is generated. Insulin resistance is a risk factor for cardiovascular disease, as is glucose, although glucose is a weak risk factor. They're improved. Weight loss, another risk factor for cardiovascular disease. These drugs make you lose weight. You get an increase in Ang-1,7, which is the protective angiotensin, not angiotensin 2, which is the bad angiotensin. These drugs decrease inflammation and oxidative stress. They block the sodium proton exchanger, decreasing intramyocardial sodium concentration. And then an interesting publication suggested that at least half of the benefit in terms of cardiovascular disease might be due to the increase in hematocrit that occurs by stimulation of erythropoietin. So there are a lot of mechanisms in addition to the hemodynamic and metabolic theory, and you'll see over the next several years a lot of work to sort out exactly how these drugs are working. Now, on the left, I want to show you one of the early GLP-1 receptor agonist cardiovascular studies, the LEADER study. And on the right, I want to compare it to the EMPA-REG outcome study. So if you look at the two curves in the EMPA-REG outcome study, you can see within 3 months, the yellow and the placebo curves are separating. So the effect, the beneficial effect of empagliflozin to decrease mortality in the EMPA-REG outcome study occurs very, very quickly. In contrast, look to the left in the LEADER study. So with Victoza, a GLP-1 receptor agonist, it takes at least 12 months for the orange and the yellow curves to separate. So again, these drugs are working by very different mechanisms. It's very likely that liraglutide is working by anti-atherogenic mechanisms, whereas empagliflozin and the other SGLT2 inhibitors are working via hemodynamic and substrate metabolic shift mechanisms, again, suggesting that probably these two drugs can be combined, not only to get additive effects on A1C, but who knows, maybe to get additive effects in terms of prevention of cardiovascular disease. Now, I promised, I told you I'd turn to the kidney, and now we are time to look at what these drugs do. But before I turn to how these SGLT2 inhibitors work on the kidney to protect your kidneys, I just want to show you one study that demonstrates quite dramatically that a reduction in GFR is a major, major risk for cardiovascular events. So I've taken this study from a large healthcare system with over 1 million adults. And in this healthcare system, they're both diabetics and non-diabetics. And it really doesn't make any difference whether you look at the diabetics or the non-diabetics. I've plotted both groups together. Compared to a glomerular filtration rate above 60, once your GFR gets to less than 60, okay, or around 60, what you see is the risk for cardiovascular event is increased 2.1-fold. And as you go to lower GFRs, down to a GFR of 15 to 29, there's a 21.8-fold increase in the risk of having a cardiovascular event. So kidney disease is a major risk factor for cardiovascular disease. So we would like a drug that not only decreases cardiovascular events, which I just showed you the Sglt2 inhibitors does, but also protects your kidneys. So in every one of these cardiovascular outcome trials, there was a series of secondary renal endpoints. There was a composite endpoint to the right, but let me take you across. Canagliflozin, empagliflozin, dapagliflozin. Decrease in macroalbuminuria. You can see 28 to 38%. Decrease in doubling of your serum creatinine, a very serious endpoint. In people with a GFR less than 40, okay? You can see 40 to 46% reduction. And then a progression to end-stage renal disease or dialysis, okay? About a 50% reduction. And if we now look at the decrease in a composite endpoint, which is development of macroalbuminuria, doubling of your serum creatinine, or advancement to end-stage renal disease, you can see 30 to 47% reductions. But the renal outcomes in all of these studies are secondary endpoints, cannot get you approval by the FDA. So the approval came with the Credence study. 4,401 type 2 diabetic patients with either a reduced GFR or the presence of macroalbuminuria. And the primary composite endpoint is end-stage kidney disease and or renal or cardiovascular death, as well as secondary endpoints, which are the individual components. Okay, let's see. If we now look at the hazard ratios stratified first by all subjects, the hazard ratio for the primary endpoint, which is combined, a combined cardiovascular renal endpoint, hazard ratio is 0.70. But now let's look at this combined endpoint stratified by GFR. Whether you have a very low GFR, 30 to 45, 45 to 60, 60 to 90, you still get protection against cardiovascular events and renal disease. So let's now sort this out and look particularly at the renal specific outcome. So the renal specific outcome of end-stage renal disease, renal death, or ending up on dialysis is shown here. If we look at all subjects, hazard ratio is 0.66, 34% decrease. But even if you look at them by subgroups of GFR, 30 to 45, 45 to 60, 60 to 90, significant benefits in terms of renal protection. So in this study, there was a marked reduction in the number of people going on to end-stage renal disease, as well as marked cardiovascular protection. So how do these drugs work on the kidney? There are multiple mechanisms, but I'm just going to go through with you briefly the mechanism that's most commonly cited. So if you're a type 2 diabetic, both type 1 and type 2, you have an excess amount of glucose in the blood, so you filter more glucose. So in the proximal tubule, there's more glucose, and there you reabsorb more glucose, and importantly, you also reabsorb more sodium with it. This leads to a reduction in sodium delivery to the juxtaglomerular apparatus. Because there's reduced sodium getting down to the JG apparatus, the kidney thinks that the intravascular volume is decreased, is being underperfused. So it sends a signal to the afferent, the little arteriole going into the kidney. It says vasodilate. It sends a second signal to the efferent arteriole, says vasoconstrict. And the net result is to increase blood flow into the kidney, increase intraglomerular pressure. And on a long-term basis, it gives you hyperfiltration. It looks like your kidney's filtering okay, renal hypertrophy, but this high intraglomerular pressure on a long-term basis damages the kidney. The Sglt2 inhibitors take the efferent arteriole and they vasoconstrict. Less blood flow going into the kidney and decrease intraglomerular pressure. Angiotensin converting enzyme inhibitors take the vasoconstricted efferent arteriole, the arteriole come out of the kidney, vasodilate, decrease the intraglomerular pressure. So because ACEs and ARBs and the SGLT2 inhibitors work in different mechanisms, afferent, efferent, arterial, you can put them together and get a marked protective effect on the kidney. Now, the abundance of evidence from these cardiovascular outcome and renal outcome studies have now changed the American Diabetes, European Diabetes Association algorithm for glycemic control. So they still recommend metformin as first-line therapy. For those of you who know my background, I actually disagree with this. I like metformin. In fact, I'm the one who single-handedly brought metformin to the United States in 1995. But metformin is not my first drug of choice in diabetic patients. I prefer GLP-1 receptor agonists, SGLT2 inhibitors, and pioglitazone. But nonetheless, now the ADA still stays with metformin. But now this is very important. They say if your patient has atherosclerotic cardiovascular disease, the second drug on board should be a GLP-1 receptor agonist or an SGLT2 inhibitor. They say if after metformin, the patient has heart failure, the second drug on board should be an SGLT2 inhibitor. If the patient has renal disease as the predominant problem, the second drug on board should be an SGLT2 inhibitor. In a certain way, this doesn't make any sense to me, okay? If you already had a heart attack, why do you want to treat the person with metformin first? Should be putting the person on a GLP-1 receptor agonist and SGLT2 inhibitor. If you have renal disease, why do you want to start with metformin, okay? You should be starting with the SGLT2 inhibitor. So maybe to satisfy the algorithm approach, you could start with metformin plus the GLP-1 or metformin plus the SGLT2 inhibitor. But there's only one true algorithm. That's the Fronzo algorithm. And that algorithm starts with the GLP-1 receptor agonist, SGLT2 inhibitor, and pioglitazone right from the beginning. Now, unfortunately, we are dealing with this COVID-19 epidemic. And people with diabetes, people with underlying heart and renal disease, our elderly population, and people who are frail are at increased risk for this infection with the SARS-CoV virus 2. And if they get the infection, they are subjected to a more severe infection. So you're going to have a lot of diabetic patients in your practice who are now going to come down with this viral infection. This, of course, is the reason why I'm not there in Egypt giving this talk, because all flights have been canceled. So I would say you're not going to treat the patient any differently than you're already doing. But there are some measures leading up that you need to be aware of. Of course, if you have someone who has symptoms, you need to have this patient come in, you need to talk to them, examine them, and they need to have a test for the virus. And if it's positive, and then depending on the severity of symptoms, then you'll have to make a decision, which we'll see in step 2, as to whether the patient needs to be hospitalized. If they're asymptomatic, then I think they can go home and stay in quarantine for 14 days. But now, if they come and they're very symptomatic, you get a chest x-ray and they have evidence of pneumonia, or you hear things in their lungs, they're going to have to be hospitalized. Before this, they can be treated at home with hydration and acetaminophen to control the fever, okay? But I think once they start to develop pulmonary symptoms, and if they're short of breath, home glucose monitoring and talking to the doctor over the phone no longer is going to work. These people are going to have to be hospitalized. And also, equally important, you need to find out who these people have been in close contact with. And if they've been in close contact with people, you need to bring them in. You also need to test them for the virus. And again, these people need to be quarantined for at least 14 days. But now, let's say you have a diabetic patient. Now, if the patient has the viral infection, like any other viral infection, they're going to be stressed. Catecholamine levels are going to go up. Catecholamine levels in epinephrine inhibits insulin secretion. they make you insulin resistant. Cortisol levels are going to go up. Cortisol makes you insulin resistant, inhibits insulin secretion. So it's very likely their diabetes is going to go out of control. Now, I've heard a lot of people say that you should discontinue SGLT2 inhibitors. Why? Because they can cause volume depletion. If you're on an SGLT2 inhibitor, you're in completely normal salt and water balance, but at a slightly decreased intravascular volume. So as long as the person can stay hydrated and drink, I don't think you need to stop the SGLT2 inhibitor. But if they're sick and they're not able to take fluid in, then of course the SGLT2 inhibitor should be stopped. And in all likelihood, those patients are going to need to be hospitalized anyways. Metformin should be used cautiously. I don't think you need to stop it. The concern here is, of course, the development of lactic acidosis. But you're only going to see this if there's renal failure. So again, I don't think that you necessarily need to stop the metformin. Sulfonylureas, well, I don't use them, period, so it's not going to be a problem in my practice, but they're usually worldwide the second-line drug to metformin. Here, the major issue is going to be hypoglycemia, and particularly if these people are getting GI symptoms, they may not be taking in food. Hypoglycemia could be a problem. Now, DPP-4 inhibitors and GLP-1 receptor agonists are safe and can be used, in my opinion. Now, it's interesting, interesting information is now coming out with the DPP-4 inhibitors, because the DPP-4 inhibitors, of course, they bind to the DPP-4 receptor. So it turns out the DPP-4 is a receptor for the coronavirus, and I've given you the reference to this if you want to read this. So some people have suggested that maybe if you block the DPP-4 inhibitor, you will block the ability of the coronavirus to then attach to the type 2 pneumocytes in the lung. The evidence for this, in my opinion, really is non-existent, okay? So I would say this is interesting speculation, but we have no evidence at the present time that DPP-4 inhibitors are going to have any beneficial effect in diabetic patients. They may, it remains to be seen. We need to have more data on this. Same thing, GLP-1 receptor agonists, they effectively lower blood glucose. I've given you an article that Dr. Schwartz and I wrote many years ago. In my opinion, these drugs are actually the most effective drugs, even more effective than insulin, for maintaining blood glucose levels without causing hypoglycemia in the perioperative period of people going to surgery in intensive care units. Never been looked at in any way in folks with the coronavirus, but I'm sure they'll be quite safe and effective. And then, of course, the tried and tested medication is insulin. We have extensive experience with it over many, many decades in controlling glucose in critically ill patients who are hospitalized in intensive care units. So I think the approach to treating the diabetic patient is really not much different than who's infected with the coronavirus than the person who is not, okay? Same drugs are available. What's important is to monitoring with home glucose monitoring or in the hospital with on-site glucose monitoring, and then adjusting medications as indicated. Now, there are lots of novel drugs that are being tested. You heard a little bit about one of these earlier, remdesivir. There has been a large phase 2b study that looked very good. There's a phase 3 study that's going on. Of course, this drug has not been approved for use. If you happen to be one of the centers that are participating in this trial and you have someone who's deteriorating with this infection, of course, it would be worth a try. Chloroquine, I think the results are quite conflicting, and we don't really have a very good controlled trial telling us whether it is or is not of benefit, okay? Now, I'm not sure what happened here, okay? that was and I'm not sure whether I'm on screen or not, but that was the last slide that I was going to show. I would like to open this up to,